All right. So I do have a grant on this, but it was a few years ago, so that's not really relevant. My only other disclosure is I'm on the board of directors for the International Pain and Spine Intervention Society. And I guess relevant disclaimers otherwise are I do these procedures, but I'm not a surgeon. And I'm going to briefly talk about the cervical spine at the end of the talk, but we'll use the lumbar spine as the foundation for going over the principles for treating facet pain. The principles are the same across the spine, but the numbers are different. So the main theme here today is going to be that treatment success for facet pain depends on selecting your patients well and using proper technique. And that is probably not that different from having successful outcomes with a lot of surgical procedures, right? One thing that makes this more challenging is that the facet joints in general are considered a cause of low back pain. And I think we can all appreciate how challenging it can be sometimes to properly diagnose why someone has back pain. You know, if someone has a disc herniation and an L5 radiculopathy and they have some foot drop, that's very easy for us to diagnose, especially once you get the MRI and you see the problem. But as we all probably appreciate, when someone shows up to our office reporting low back pain, it's not as straightforward as diagnosing exactly why their back hurts. So we're going to try to explain that in terms of what the actual prevalence is in terms of facets being the cause of low back pain, and then go over maybe ways that we can diagnose this properly, although you'll see from my slides that's still challenging. And then I will mostly talk about treatment in terms of radiofrequency ablation, but I'll briefly talk about intra-articular injections as well, because those are still, people have lots of questions about them, even though we don't end up doing them very often as treatments anymore. So this is going to be the bulk of my talk, understanding this slide. And it looks like a boring slide, but it's an important one. And this formula, which I think we sort of learned in medical school, but not in this much detail, highlights that our confidence in making a diagnosis, which is considered our diagnostic confidence, really depends on two things, right? So one is the population prevalence, and then the other is the test, or how good the test is. And both of these things are important when trying to understand if we've made a correct diagnosis. So an extreme example would be if I was on the obstetrics floor and there was a woman in labor and I gave her a pregnancy test and the test came back negative, I'm still probably pretty sure she's pregnant, right? Because the pre-test prevalence is so high, and maybe something was wrong with the test. And the opposite can be true too. If I gave a pregnancy test to a male and it came back positive, odds are they're not pregnant. They probably have something else that caused that test to be a false positive test. So we're very good in medicine at looking at a test result and saying, well, it's positive, that means you have the problem, or it's negative, that means you don't have the problem. But we often, I think, overlook, or at least the people that I work and train with, including myself, sometimes aren't as good at questioning the results of the test. And what should give us pause when questioning test results would probably be what our pre-test probabilities were, which all things being equal, if you don't have any other information, is going to be your population prevalence of the condition that you're testing for. And so we're going to go through this without doing too much math, but this is going to be the bulk of how I want us to think about facet pain. This slide here is the most cogent summary of what we understand the prevalence of facet pain to be. This has not been replicated in lots of studies, so there's probably some room for better understanding this. But as we look at this in the lumbar spine, we see that in younger patients, you know, as I get older, I think younger means something different. But if we look at patients here 30 to 40, the prevalence of facet pain is less than 20%. It's somewhere between 10 and 15%. And maybe later in life, in our 60s and 70s, it might get up to 40%. It's never more than 50% in the lumbar spine. And that's important information for us to know. That means that most of the people that present with low back pain don't in fact have facet pain. And the other take-home point that I think is important from this slide is that young people that have low back pain almost assuredly don't have facet pain. And there's a good reason for that. That's because, at least in the lumbar spine, the most logical explanation for why the facet joints can be painful is that as they are synovial diarthrodial joints, they behave similar to other small diarthrodial synovial joints, right? So if we think about getting hand pain and arthritis in our hands, that's something that develops with age as the joints degenerate. And, you know, if you're a young person that has hand pain, you probably don't have osteoarthritis. So young patients that have facet pain, there may be another cause, but the most likely cause of facet pain is osteoarthritis, and therefore it's more common in older people. Another way I try to explain this to people if I'm teaching my trainees, let's say, is if you're a 25-year-old and your knee hurts, and you went to your neighborhood friendly local sports doctor or orthopedic surgeon, and they told you, and we're all physicians here, right? If you're 25 years old and someone said, oh, your knee hurts because you have osteoarthritis in your 20s, you would think they're either wrong or that you have some other serious underlying condition, or more likely that you have some other cause of your knee pain, like a meniscus tear or a ligamentous injury. And that's true with back pain too. In fact, one of the things I see people do wrong most awfully with this is diagnose and treat young people for facet pain. And more often than not, that doesn't lead to the outcomes they want. And that's because they were treating a problem that wasn't there. If we look at certain studies that we'll talk more about radiofrequency ablation later, and how it's diagnosed in terms of medial branch blocks. But if you look at studies that were meticulous in diagnosing facet pain as the cause of their low back pain before treating them, we see that in John McVicker's study out of New Zealand, he screened almost 600 patients to get down to 106 patients that he diagnosed with facet pain. And then in Paul Dreyfus's kind of early but pretty seminal study, even if you just look at the 138 people they screened in person, they ended up only treating 15 of those for facet pain. So a good rule of thumb is that most people you see with low back pain don't have facet pain. And the people that you do think have facet pain, if you go through rigorous diagnosis, you're going to find out a lot of times your clinical suspicion was wrong, and you might have thought they had facet pain, but after doing a rigorous workup, you'll find out that they in fact had a different cause of their low back pain. So it's a very common thing for us as physicians, obviously, to want to know how we diagnose things. And we're all taught the tenets of using history and exam, and then other tests such as imaging to make a diagnosis. And this is probably what makes diagnosing facet pain so challenging, is that when people have studied this, Dr. Schwarzer is another physician out of Australia, I believe, we have a lot of trouble finding reliable predictors of facet pain. So a very common quote in talks and textbooks that comes from his somewhat famous study is that when they evaluated this, there was no specific clinical features that reliably differentiated facet pain from other causes of low back pain. Other people have looked at this as well, and they found things that we would even think might be specific to facet pain, such as pain not radiating down the leg, not necessarily being specific. And then another study by Mooney found some things that were predictive of facet pain. And I think most of us in this arena of medicine believe these to be somewhat true. And that's there's generalized low back pain in the paramidline structure. So it's not perfectly midline pain. And it tends to be in the low back, and it might refer further down the leg, but pain referral patterns also are not helpful with differentiating facet pain from other causes of low back pain. When Dr. Schwartzer looked at the physical exam, suffice to say, they had the same conclusion that there was not any specific physical exam test that they could identify that reliably diagnosed patients of having facet pain. And that seems really challenging again, right? If I'm telling you that there's nothing a patient can say, and there's nothing that I can do in clinic in examining the patient that's going to help me diagnose it. The question is, should we do a history and exam? Or the other question is, well, how do we identify those patients? This isn't surprising that these studies found it. And this is a separate group of authors who are interested more in physical diagnosis of low back pain. And when they just looked at all exam maneuvers for all types of low back pain, so disc pain, sacroiliac pain, or facet pain, they found that the kappa values were extremely low, which is 0.2. And kappa values are a measure of the inter-rater reliability. And so what this tells us is we're probably, as a whole, as a group of physicians, have trouble diagnosing low back pain, because when I examine a patient, and then when my colleague examines a patient, and then if a third person examines the patient, even if we did the same exam maneuvers, we were most likely going to have different results from those tests, and thus that's going to lead to different outcomes. So if we can't even do the exam in a way that gets us the same results, it's not at all surprising that we can't do an exam that's going to reliably predict the diagnosis, because the results of the test might be more dependent on who's doing it as opposed to what the test is. So this is the challenge we face in diagnosing low back pain. And I'm not trying to be too much of a naysayer on physical and exam. It's part of what we do as physicians, and as a physiatrist, my field probably takes a lot of pride in doing good physical exams. But wanting something to be true or thinking we're good at it does not mean that we should ignore the science, which shows that there's a lot of variability in this when we try to research it. So I believe the studies that say facet pain is hard to diagnose based off of history or exam, but I do think there's some utility, and I'll go over how I think these are still useful for us. So what is it good for? Well, the first thing is that facet pain is relatively rare. So if the diagnosis is rare and we now have a history and exam that suggests a different cause of low back pain, now we know that facet pain is even more unlikely. So what does that mean? Well, if we consider facet pain to be an osteoarthritis type pathophysiology that builds over time in the elderly patients, there are things that we could consider aren't consistent with that diagnosis, right? So acute onset pain is probably not likely to be facet pain, because most people don't wake up one morning with 8 out of 10 arthritis pain, no matter what joint you're talking about. Same thing with pain severity. Now, if arthritis builds over time and is untreated, it might become severe. But same, if you wake up and you have severe pain, that's not likely osteoarthritis, right? If you have no knee pain one day and the next day you have 8 out of 10 knee pain, that probably means you have an injury to your knee. That probably doesn't mean that you rapidly developed arthritis. Lumbar facet pain can refer, down into the buttocks, but when we think about pain referral, it still should emanate somewhat close to the source of back pain. So if patients have pain exclusive to the belt line and below, that's again more likely to be something else like hip pain or sacroiliac joint pain. And similarly, if you have pain that's exclusively midline, that's more likely to be something to do with the anterior column, right? A vertebral body injury or an intervertebral disc problem. Even though I just told you exam maneuvers aren't reliable, we can still think about biomechanics. And we know that in general, extending or rotating and extending is what's going to load the facet joint mechanically. So that might induce pain. But perhaps more importantly, we know that flexion-based pain is very specific for loading the anterior column. And so if someone hurts when they bend over, that's at least somewhat more likely, again, to be the vertebral body and the disc. If you do, like we have very well-established physical exam maneuvers for the hip, for the SI, it's a little more complicated, right? But if you do an exam and it's telling you that there's something with their pelvic girdle or their hip, again, that's probably not likely facet pain. And then some patients can have somewhat proximal symptoms from their radiculopathy, but those are going to present differently too on exam, right? So if someone has positive neural tension signs, that's unlikely to be a facet problem. If they have pain in their back or their buttocks, but have abnormal neurologic exam, that's probably more related to, radiculopathy or a disc problem. And then other things that we know are specific to other causes of pain, such as midline percussion is a specific test for vertebral body fracture. If that's present, that again is also unlikely to be facet pain. So even though we can't necessarily positively diagnose facet pain with history and exam, we can do lots of other things that can rule in other causes of pain or make us think the source of pain is something else. And if our clinical judgment is leading us to believe a different diagnosis is present, then it's a relatively sure thing they don't have facet pain, if that makes sense. So a general presentation in terms of someone that has facet pain, even though none of these are that specific, are going to be a patient that has somewhat advanced age. The pain's going to be paramidline, so over the structures just lateral to the spinous processes, but not midline pain itself. The pain's going to be at least maximal in the lumbar spine, even if it's somewhat referring. And this typically occurs more in the lower lumbar spine at L4-5 or L5-S1. And conversely, younger patients that have flexion-based pain, patients that have midline pain over the spinous processes, or pain that radiates really distal to the knee, those are less likely patients to have facet pain. Imaging has its similar challenges. So again, everyone that's looked at this comes up with the general conclusion that there's no specific correlation between routine imaging and the presence of facet pain. And again, that's probably expected because we know that if you image a bunch of 60 or 70-year-olds, almost all of them are going to show spondylitic degenerative changes in their spine, right? They're all going to have some disc degeneration and some facet arthropathy, and yet not all of those patients are going to hurt. So because of that, if you do a study where you're looking for common image findings to be correlated with a rare condition, it's going to be hard to find that relationship. Other people have looked at more refined tests. So there's a little bit of literature showing that SPECT CT abnormalities might be predictive to treatment of facet pain. And while at least in the United States, SPECT scans have become somewhat more common recently, again, over the last 10 or 20 years, that's largely been replaced with MRIs. And there's a little bit of research there as well, showing that on fat-saturated MRI sequences, if you see increased edema within the facet, that may correlate with them having symptomatic facet arthropathy as opposed to kind of incidental facet arthropathy. So this is one image on your right here where there's effusions within the facet joint, which are not quite the same as periarticular edema. But if you see something like that, that may be related to facet pain. Although we should also, in this type of patient, be aware that large facet effusions are also somewhat predictive of there being spinal instability. So you'd have to rule out mobile spondylolisthesis. And then otherwise, you might find some joints that are at the end of their degenerative cascade, right? So here we have an example of the facet joint on the right that has a subchondral cyst, right? And if we think about what we know about osteoarthritis, where you have thinning of asymmetric thinning of joint space, osteophytosis, and subchondral cysts, at the end of that spectrum, if you see a really arthritic joint, it maybe makes intuitive sense, at least, that maybe is symptomatic. But that, again, is not founded by good research. That's more extrapolating what we understand from other joints. And then one thing that may be overlooked is that there's something called facet tropism, which is if the angles of the facet joints are asymmetric, that is likely a exposing factor to someone developing symptomatic facet joint at that level. So it's a good idea to remember to look at the angles of the joints and look for asymmetry. And if there's asymmetry, one of those joints may be overloaded and thus become a symptomatic cause of their low back pain. The last thing to briefly mention here, my slide's not great, but if you see synovitis within the joint, it could just be a degenerative problem. But if you see active synovitis in multiple joints, that's probably a pretty specific cause of their low back pain. But you also should consider working them up for a spondyloarthropathy because they may have an underlying rheumatologic condition that predisposes them to synovitis. Similar to history and exam, imaging can point you away from the facet joint. So on this slide here, on the left, we have a picture of annular tear, which there's pretty good research that that's about an 80% specific radiographic finding for symptomatic discogenic low back pain. And then on the right here, we have various stages of modic findings. And while some, such as type 2, may not be as specific for low back pain, something like a type 1 modic change is also 80 to 90% specific for that being the cause of low back pain. So again, if we think that facet pain is a relatively uncommon cause of low back pain, and then we see a radiographic feature such as an annular tear or modic change that has 80 or 90% specificity for the diagnosis of disc pain, you can use this imaging to confidently conclude that the patient in all likelihood doesn't have facet pain, and thus treating them for facet pain is probably not a good idea. Some of this research, like a lot of diagnostic research, is prone to circular logic, right? Because you have to consider one test to be the reference standard on how to diagnose a problem. And most people in this line of work would consider a diagnostic injection of the medial branch to be the test that's most reliable in diagnosing facet pain. So a medial branch block is a commonly used term for this diagnostic test. And really all this is anesthetizing the medial branch of the dorsal ramus, which innervates the joint. It innervates a few other things, but the thought being if you anesthetize the medial branch and they have an immediate resolution of their pain, then that has pretty good face validity as being diagnostic for their facet joints being the cause of their low back pain. But this test has its problem. So this is a slide here showing the neuroanatomy of the medial branch, just showing there that it comes off of the dorsal ramus. And this nerve is accessible to us. It's reliably located in this groove between the superior articular process and the transverse process, and then is anchored by the mammalo-accessory ligament that goes from the mammillary process to the mammillary accessory process. So this nerve sits right here on the spine in almost every patient. And each joint is innervated by the nerve that's above and below it. So the L4-5 joint is going to be innervated by the medial branch over the L4 and the L5 transverse process. It's worth noting that the nomenclature gets a little messy because, as you see here, the nerve over the L5 transverse process is actually the medial branch off of the L4 nerve. So technically in the lumbar spine, the L4-5 joint is innervated by the L3 and the L4 medial branches, but there's no point getting too worried about that because structurally the L4-5 joint is innervated by the nerve that's over the L5 and the L4 transverse process. This is just that. I'm going to skip over this. It's messy, but another description of how the nerve comes off the spinal nerve down through the groove and then branches back up into the joint at that segment and branches down to the joint below. And these are pictures of properly done medial branch blocks. So you'll see the needle tip is located right at the juncture of the superior articular process and the transverse process. Note here the needles are coming in obliquely because if you come in directly down onto this, your needle will get stuck on the joint and not get in underneath the joint. And then ideally, you're going to use contrast to ensure that your medication is covering the target that you intend. So that's what a medial branch block should look like. And I go over all of this to bring us back to this point here, which is our diagnosis. Our confidence in diagnosing facet pain is dependent on the prevalence, which we've talked about a lot, but also dependent on how good the test is. And I just told you that history and exam is relatively poor in that we use medial branch blocks to make this diagnosis. But even if it's the best we have, it's certainly not a perfect test. So we need to understand a little bit more about this test so we know how to interpret it. So this is another study by Dr. Schwartzer, and they did the test, a medial branch block. They did it twice. And what they found is in a significant number of patients who had a positive block on the first occasion, had a negative block on the second occasion. And if you take this 2x2 table and put it into the proper formula, what you find is that there is a false positive rate of this test of upwards of 38%. And if you stop and think about it for a while, that's a pretty complicating thing to incorporate into our diagnosis, because now if I have a condition that has a low prevalence, but the test has a high false positive, that means I'm still going to end up doing the test on patients and getting a positive result, and pretty frequently incorrectly diagnosing them with facet pain. So what that means is if you go into that formula I've shown you and you consider the low prevalence of facet pain and the high false positive, the diagnostic confidence after a single block only marginally increases. And I have a few number examples to show you, right? But if you have a pretest probability of 30% and a test with a 30% false positive, a positive result is still only going to make your diagnostic confidence about 50%. And I think we'd all agree as physicians, we don't like to be right only half of the time. So that led to at least it's in practice, based on theory, the idea that you do the test twice. Because if you do the test twice, your post-test probability after the first test becomes your pre-test probability before the next one. And so you can increase your post-test probability the more you repeat the test and get the same result. So if you ever hear the term dual medial branch blocks, all that means is doing the test twice and requiring a positive result on both occasions. So without bogging you down too much, I used to have slides where I had number examples of all of this. But if you approximate a positive likelihood ratio of about 3, which is what you get if you do a test with a false positive of 30 to 40% and do it twice. You'll see some common pitfalls here in terms of diagnosis and treatment of facet pain. So if I take someone with a 10% pretest probability, so a young person, and I do medial branch blocks twice, which is still a likelihood ratio of about 3. If you put those numbers into the formula that I showed you, our post-test diagnostic confidence is still only 24%. So what that means is if I do medial branch blocks on a 25-year-old and I diagnose 4 of those 25-year-olds with facet pain because they had 2 positive blocks, in reality, only 1 of those 4 has the condition and the other 3 I've misdiagnosed. So I think it's a fair rule of thumb to say that you probably don't want to even consider trying to diagnose young people with facet pain in general, because more often than not, the test is going to give you the wrong result. If you use this test on patients who are more likely to have facet pain, such as someone who's 65 or 70 years old, who may have a pretest probability of closer to 40%, then this test, which is the best we have, but is still not a perfect test, after that test being performed twice, our post-test diagnostic confidence gets up to 65%, which isn't great, but it's a lot better than 24%. It's better than 50%. And if I can properly diagnose and treat 2/3 of my patients that are in their 60s and 70s, I'm going to help a lot of people. The other thing to remember, though, is if our diagnosis can't get better than 65%, that probably means our treatment outcomes are also not going to get much better than 65%. I have a question. I'll try to answer it at the end here. So why do we go to such lengths at making a proper diagnosis? And the answer to that is, let me try to hide this, is that making this diagnosis also predicts our ability to treat with radiofrequency ablation. So the test is not only diagnostic, but it's also prognostic. It helps us predict who we can treat effectively. So a radiofrequency ablation is just essentially the definition of that is that you're using radiofrequency energy to generate a thermal lesion that's going to denervate the facet joint, right? So it makes sense if you anesthetize the nerve and the pain goes away, that if you then permanently or semi-permanently destroy that nerve, hopefully their pain goes away on a longer lasting basis. And when we think about radiofrequency ablation, there's 2 things to consider. The first is that if the patient does not have the condition being treated, the patient can't respond to the treatment, right? So if someone has abdominal pain and you do an appendectomy, but they didn't have appendicitis, you're not going to fix their abdominal pain. And the same holds true with the low back. So turn my lights back on here. If someone has, intervertebral disc pain, and then you treat them for facet pain, the treatment's going to be ineffective because you've treated the wrong cause of their back pain. The other thing that's important to remember about radiofrequency ablation is that if the nerve isn't captured by the thermal lesion, the treatment's going to be effective, right? So if your needle doesn't create a thermal lesion where the nerve is, the nerve survives, their pain will persist, right? So similarly, if someone has appendicitis and you thought you did an appendectomy, but you left their appendix in, they're still going to have their abdominal pain. So the treatment only works in patients who have facet pain, and it only works if you actually do the procedure properly. And what that means, similar to lots of other intricate spine procedures, is that technique matters. So when you look at the electrodes, this is a study in an animal model, but they tried to map out, how big is the lesion you get when you use different electrodes. you see that if you use a large gauge needle, such as a 16 gauge or an 18 gauge needle, you get a little bit bigger than a 1 centimeter square lesion. And if you're using a much smaller needle, like a 22 gauge needle, your lesion is less than half the size. And so it makes sense that if you're using a small needle, your lesion isn't as big, you're more likely to miss the nerve, and therefore it's less likely to be effective. The other thing that matters when we do this procedure is how we put the electrode over the nerve. So this is an example of where, here is the transverse process and the superior articular process, and this is the nerve running in that groove. It's a lateral view, obviously. If you try to place a needle down perpendicular to the nerve, you can see you have to be very precise to catch the nerve. If you were half a centimeter too medial or too lateral and your needle isn't directly down on the nerve, you'd miss it. And you also see from these slides that the lesions from these needles extend along the length of the needle tip. They don't project outward from the tip. So in the case below here, only this bottom part of the lesion would get the nerve. Conversely, if you're able to place the electrode parallel to the nerve, you can see here, it's a lot more likely that part of your lesion, which is the red tip here, is going to at least span the nerve somewhere. And then if you use a larger needle, you've now greatly increased the chances that you're going to ablate the nerve and thus treat the patient successfully. And as mentioned, this is something I'm researching and we're almost done, but I'm pretty confident our research is going to revalidate that how you do this procedure is very important. So this is what it would look like under a fluoroscopy image, right? So you have this needle coming in from an oblique approach and it's caudal to the target. So you can lay the needle parallel to where the nerve traverses the superior articular process and the transverse process. See, if you have a larger needle, you're more likely to capture the nerve. And this may seem, I hope this seems to you like a no kidding, why wouldn't you do this kind of logical thought process? But unfortunately, that's not the case. So there's other people that do these procedures. This is a published image from another study done on this, where they've used small needles and they're coming in from a perpendicular approach. And if you just, I have to give Nick Bogda credit for this slide, but if you just map out where the nerve is based on the fluoroscopic anatomy, and then use the orange circles here represent where the thermal lesion is, you could see that doing this procedure this way, at best, you probably only maybe nicked one of the three nerves and the other two nerves were unaffected. So someone could call this a radiofrequency ablation. And in fact, people have published on this showing relatively poor outcomes. But even if you call it a radiofrequency ablation, if you didn't actually ablate the nerve, it probably is more of a sham or scam type procedure. If you take for granted the things that I've talked about so far, saying if you select patients well and you do the procedure properly, and the first two studies I'm going to go over here are cherry picking studies that did exactly this, that selected patients rigorously and did the procedures in the most technically meticulous way. These are the outcomes you see. So the study by Dreyfus, where they looked at 138 and they excluded patients with neurologic problems, radicular pain, significant disc degeneration. You got down to 41, and then of those 41, you did medial branch blocks, and 22 of the 41 had a positive response the first time, and they repeated the blocks, and only 15 of the 22 had a response the second time. And then you did very meticulous radiofrequency on those 15 patients using a parallel approach and a large needle and multiple burns because they had a 5 millimeter needle. This is their procedural images. These are their results, and this is a messy slide, so I'll show it to you in an easier to understand way. But what they found was pretty, I mean, if you think about how relatively not good we are at treating back pain, these are pretty phenomenal results. They found that over 80% of patients had 60% improvement or more of their low back pain. And almost 2/3 of patients had 80% or more of their back pain gone with this treatment, right? So that's great. I don't know of very many procedures where I can have 60 to 80% success rates, or that patients are going to tell me their back pain is 80% better. John McVicker did a very similar study, but had a lot more patients. So they looked at 500 patients. They did 2 blocks. They got it down to 106 patients who had positive response to 2 medial branch blocks. They were performed the procedure with 16 gauge needles, and they did multiple lesions with 16 gauge needles. And in this study, they defined success as the patients reporting 80% or more relief, restoration of all their desired activities of daily living, not requiring any additional healthcare for low back pain. So no doctor's visits, no emergency room visits, no medications. And if you were unemployed, that you'd return to work, which I think we'd all agree is a very high bar to achieve. You know, if we could do this for our patients, we would all be very happy. And what they found here is, I'll draw your attention to the bottom of the screen. They had about 60, just below 60% success, which is amazing. If I have a patient and I say there's a 60% chance that I'm going to make you pain-free, not need to go to the doctor, do whatever you want, and return to work, that's a phenomenal treatment for low back pain. So if you do this properly, you can get really good results. They also followed these patients longitudinally and allowing for repeat procedures, which not everyone needed a repeat procedure. As you see, all these patients at the bottom only had 1 treatment. But what they found was that if this treatment's successful, the average duration of success is 15 months. So a lot of people say 6 months. That's wrong. The average treatment success is going to be 15 months. And many of these patients, like this patient down here, was going on 2 years and still never needing a repeat procedure. So this is a very durable response if it works. And if it works and your pain comes back, you can repeat it, and more often than not, the pain is relief is reinstated. So conclusions from rigorous research is that if you use proper patient selection and proper technique, you can have really good outcomes, and the relief is durable. Unfortunately, not all the research is done like that. So when you do reviews of the literature, like this systematic review we published, you have to start to stratify on how they selected their patients and what technique they utilized. And unsurprisingly, you find that if you start weakening those criteria, the success reliefs go down. So if you use a perpendicular lesion instead of a parallel lesion, you'll find that success rates are only between 12 and 40%. If you use a single medial branch block, the success is about the same, the success rate, but the degree of relief is a lot less. So only 50 or 60% of people will feel 50% better. And it's only if you use 2 blocks with a high degree of relief and proper parallel technique do you get up to 65% of patients feeling 100% better. And I find this number to work out very conveniently, that we started the talk saying, even with 2 blocks, your diagnostic confidence is only 65%. So until we come up with a better way to diagnose these patients, I don't think we'll ever get better success rates than this 65% result. So people always ask, what about intra-articular injections? I admittedly am a little biased because this is a study that I was a part of, and it's the only randomized placebo-controlled study comparing intra-articular steroids to placebo or a saline injection. And we looked at 56 patients that had 2 medial branch blocks to diagnose them. And then after they had 2 positive blocks, they were randomized to saline or steroid injections. Now, keep in mind, these are also patients eligible for radiofrequency ablation. So if they weren't better, eventually they got the radiofrequency ablation, so we weren't withholding treatment. And so the primary outcome was essentially if you did a steroid injection and their pain was gone, obviously you wouldn't want to do an ablation because they wouldn't hurt anymore. But if you did a saline or a steroid injection and they came back a month or 2 months later and said, hey, my back's still hurting, then we'd go on and give them the ablation treatment. And what we found here is you can see these results there's no difference between groups. Whether you got a steroid injection or a saline injection, the vast majority of patients had return of pain within a month or two and got an ablation. So the steroids in properly selected patients had no effect over treating them with saline. So, and because of this, now in the United States, intra-articular steroid injections are not even really covered by insurance. So the result of that study was there's no statistically significant difference between intra-articular steroids and intra-articular saline. A lot of people ask about PRP and stem cell injections into the joints. That might be something we do in the future. I have a separate talk I give on that topic. But for now, I think this is a very fair summary, is that this is extremely limited data. So I would consider these experimental treatments still. In fact, as far as I know, there's only one research group out of China that looked at doing PRP or stem cell injections in the low back, and then a separate group looked at PRP injections in the cervical spine. And those are the only 2 research studies that have really been published on this topic so far. So maybe there's something here, but we don't know. I told you that I'd focus on the lumbar spine, and everything we've talked about is true in the cervical spine, except for 2 main differences. So the first is that facet pain in the cervical spine is actually more common. And because of that, it's easier or you're more likely to make a good diagnosis. And that has to do with the biomechanics of the cervical spine. But in general, we probably say the etiology of neck pain being due to the facet joints is upwards of 60%. So these patients are easier to diagnose. And on top of the cervical facet joints being prone to osteoarthritis, another common etiology of cervical facet pain is whiplash type injuries. And there's some pretty good research showing that a substantial portion of patients who have neck pain after car accidents, that it's due to the facet joints being injured. So I have a few minutes left. I'm going to go over some case examples. So, this is, would you treat for facet pain? So if you have a 35-year-old, they have 5 years of chronic low back pain, it's episodic, it's worse with bending, they have an annular tear in the MRI. The answer is no. You don't do a medial branch block on this patient. You don't treat them for facet pain because they don't have facet pain. If you have an 80-year-old woman that comes into your clinic, she has osteoporosis. She was doing a lot of gardening and never has had back pain before, and then wakes up with severe midline low back pain. Are you going to treat them for facet pain? The answer is no, right? She probably has a compression fracture until proven otherwise. But if you get a patient like this, who's a 70-year-old male, they have bilateral lower lumbar paraspinal pain, it's worse with standing, better when seated down, they have kind of generic degenerative changes on imaging, this is a good patient to do a medial branch block on. And then the question, what happens? So if you take 15 of those patients and you do 15 medial branch blocks on them, and you consider that the prevalence is 30 to 40% in this age group, but the false positive is still 30%, you're probably going to get about 10 of the 15 patients having a positive first block. Because you want to be precise, you might consider doing the test twice. And if you do that, probably 7 of the 10 will have a positive second block, and 3 will have a negative block. And then if you do the procedure properly, On those 7 patients, you'll probably fix 4 of them where they have substantial or complete relief of pain on average for over a year. So the take-home point here is for those 15 patients, I'm going to cure 4 of them, but you shouldn't look at that patient and say, I have a good treatment for you, because in 11 of those 15 patients, ablation is not going to be the appropriate treatment. I was asked to answer these other questions in my last 4 minutes. So how long does it take for facet joint pain, which is severe in the morning, to ease? If I think of a patient that has severe morning pain and they're young, I'm more worried about rheumatologic or discogenic causes of low back pain. And if they're an elderly patient with low back pain, it may be worse in the morning, but they also tend to have it persist throughout the day. Does facet joint pain increase or decrease with activity? I'd say it likely increases, right? The more you load the joint, the more it's going to be painful. Can facet joint pain mimic articular pain? I'll show you a picture on the next slide. And the answer is potentially, but unlikely. Whoops. Does facet pain increase with extension and rotation? I'd say in theory, yes, even though I told you the exam is challenging. In which cases does the facet joint pain extend into the abdominal region? That's, I mean, anything's possible, but it's probably unlikely. So this is the best picture I have of someone that mapped out lumbar facet pain referral patterns. And you'll see here, it can extend into the buttocks or the legs, but usually not distal to the knee. A few patients reported some groin pain, which maybe that is analogous to some abdominal pain, but in general, people don't report abdominal pain. But the vast majority of patients had predominantly axial lumbar pain when you map out where this hurts. And then the final few questions here in my final few minutes, if I can turn my lights back on, is can pain be caused by a facet that's not osteoarthritic? And I'd say yes, it could be traumatic. But again, that's more common in the neck, and it may be potential in athletes, but I think anytime you have posterior element pain in athletes, you have to rule out pars defects well before you ever consider the facet joints. Is it really necessary to do 2 diagnostic blocks to confirm facet pain? If the clinic presentation is distinct, should we just do RF ablations directly? I would say that today I made a case that you should do 2. I'm not married to that position. In fact, I've given talks where maybe saying 1 block would be better than 2 for health utilization purposes. And it may not affect our outcomes with RF very much if we do 1 block instead of 2. But I could do a whole hour-long talk on doing single versus dual blocks. But I would say, based off of how I interpret this data, that we should probably most often at least do 1. Is cervical medial branch block more beneficial, or lumbar medial branch block more efficient? They're both very effective. I would say you have less failures in the cervical spine because the increased prevalence means that you have better diagnostic confidence and better or easier patient selection. I got asked about position. Maybe I didn't word this properly. I'm not aware of anyone that does it in a supine position, and I think you'd be at risk of traversing some important vascular structures if you did it that way. Some people will do it in a lateral position, but if you do that, then you can't do a parallel burn. You have to do a perpendicular burn, so it's probably not going to work as well. And then the last question is how long do these treatments provide pain relief? And the answer is, on average, it's a year to year and 3 months, which means probably 50% or more of patients this works for over a year. So should be a very long lasting treatment if you do it properly. And then my question was, again, in my chat about doing 1 versus 2 versus 3 blocks. I think that from a clinical perspective, there may be times where it makes more sense to do 1 ablation. and I'm admittedly a researcher, although I spend most of my time treating patients. And we face different challenges across the world. I don't think there's a lot of risk to a patient if you do an ablation, other than it's a little more painful of a procedure and it takes longer. But I could completely buy the health policy perspective that if you just treat everyone with ablations, you're still going to get the patients that are going to get better. You're going to treat them, and the ones that you're not going to treat, instead of doing a medial branch block that you didn't need to do, you did an ablation that doesn't work. I think right now, unfortunately, with the healthcare landscape in the United States, and also just with clinical research right now, is a lot of our information now that gets published, it comes from things such as registries, health insurance registries, Medicare data in the United States, and things of that nature. And the main risk to doing ablations on everybody would be that eventually probably no one would get access to them then, because if I do 4 ablations in 7 patients, like I had on my example, and have 60% success rates, that looks pretty reasonable to payers or other critical people. But if I did 15 ablations on my example and only 4 people got better, having success rates of under 30% is probably poor enough that, at least in our country, the procedure just wouldn't be covered anymore. So the downside to being overly liberal with treatment is that the outcomes will look worse, and that might actually lead to the procedure going away. So on a patient by patient basis, it's probably not the worst thing in the world, but from a health policy perspective, it would probably be the death nail to us providing these treatments to people. And again, that logic might only apply to my country, but it's an important thing for us to consider. So I went 3 minutes over. I have time for a question or two, although I have to go do a procedure here in a minute. But if you guys don't have any questions, I'm happy to answer emails, or if someone has a burning question, I'm happy to answer it now.
Thanks a lot, Doctor, for an interesting presentation. It was so detailed, and I didn't know that Facet Pain has such kind of many perspective of views and branches. Thanks again. About our public people, if you have any kind of question, you can ask, and I can speak out. If any of you want to speak out as well, I can make you that possibility. I will ask a question from the chat, first of all. Thank you very much for your detailed conference. Performing 2 consecutive injections to diagnose facet pain is very time and labor consuming. Why don't we do radiofrequency ablation directly instead of testing? As a result, it is more expensive for the patient to go in and out of the operating room for the test than the radiofrequency material. This is first.
That's the one I tried to answer. I guess the other thing I'd briefly mention is that depends on the finances of how things run, right? So if the main cost is the operating time, then it might make sense to do 1 procedure. But a lot of the radio frequency probes now, so especially things like cooled RF probes, cost hundreds, or if not more than that, of dollars. So doing a medial branch block costs me $10 or $20 of materials, and doing an ablation probably costs me $300 to $1,000 worth of materials. So in the clinic, it's actually a lot cheaper for me to do a block. But if you're buying OR time, that might change the financial considerations for sure.
Okay. Next question. Professor Mustafa Raoğlu wanted to ask, but he left the meeting because he had some kind of issues. Okay, dear moderator, I want to ask that question. He's a lecturer at University of Bournemouth, UK. Research shows that comorbidity is quite high with non-specific chronic low back pain. Patients with chronic low back pain exhibit very high prevalence of psychosocial factors like anxiety, fear of movement, depression, and etc. These factors have been shown to be very influential in the perception of the patient's pain. In the case management of this patient, how much of these factors do you consider in your clinical reasoning and which questionnaires do you use for the outcome measure? So he's asking biases
That's a
mostly.
great question. I don't have a specific questionnaire I utilize, but in that scenario, you should always treat their other biopsychosocial factors first. And I think a lot of people overtreat facet pain and do ablations on people before considering their other complicating factors of their non-specific low back pain. And then you're just not going to get very good results. So, I mean, I do 2 to 4 of these a month only, and I probably see 500 patients a month. And I get great outcomes in those 4 or 5 patients. I've cured their back pain. But yeah, if you make a habit of treating people who have fear avoidance behaviors, or their pain is due to depression and anxiety or anything else, like we talked about, if their pain isn't coming from their facet joints, the ablation isn't going to help. And so you have to not treat those patients with a procedure. You have to treat them with other appropriate means.
I want to ask myself a question. As you mentioned that this facet pain is not so common and it's rare cause of the pain, you are using different kind of stuff to diagnose the patient, but this is not still exact diagnosing method as you mentioned. So I'm interested in, as it's rare, as it's really hard to diagnose, and if you are diagnosing, mostly you are misdiagnosing the patient if you are not diagnosing properly. What is your advice for example, young doctors? For example, I'm future doctor as well. What kind of methods we can use? First of all, like a step by step. Can you conclude all of the things, like by percentage, which can be most helpful to diagnose properly the patient, and also to use your many kind of researches and together all of the experience what you have.
Yeah, I'll try to answer that, and then I need to run. I think when you have certain things that you can rely on, those need to be your guiding lights, right? So when you see annular tears in young patients, they have disc pain, and that's not fun to diagnose because we don't have a good treatment for it. And when you have someone that tells you that they're scared to do things because their back hurts and they sit on the couch all day, and that they're depressed, they're telling you what their problem is, but that's not fun to diagnose, right? Because I can't inject it and you can't operate on it. And I think the best piece of advice I could give to people is, we all want to help people, but there's good research that as doctors, we all overestimate how much we can help and underestimate the harm we can do. And if we acknowledge that there's a lot of people with back pain we still don't know how to fix, that's going to keep us from doing a lot of unnecessary treatment, right? So acknowledging our own limitations is probably the best way to help our patients in the long run. And hopefully we get better over the next 20 years. But
Okay, doctor, do you have several minutes other doctors to speak out and ask you if they want anything, or you are running now?
If you have other questions, I'd ask that, let me pull up the chat. I'll give you my
In the
email.
chat, nothing, but I wanted Professor Emre Golbo to speak out, hopefully.
All right.
I'm not really good in Turkish, sorry.
I can answer one more question, and then I put my email in the chat. You guys are welcome to email me.
Yeah, thanks
Scheduled
for
to do procedures right now, so I have a patient that's waiting on me, but I'll answer one more question.
Professor Emre. If you want, you can speak out and we will finish our meeting now.
Hi, doctor. Thanks for really, really important knowledge about this topic. I want to ask, do you use cooled RF or bipolar radiofrequency cannulas in your routine, or you use only 10 or 5 millimeter active conventional radiofrequency procedure? Thank you.
Yeah, I do. I still use traditional RF probes. I think the other ones are probably just as good, although there's some research showing they might not be quite as good, but they're a lot more expensive. And if the slide I showed you that shows the lesion size, 16 gauge, 10 millimeter tip lesion is still just as big as a cooled RF lesion. So I'm not sure they're better. They may be just as good, but they're also more expensive. So I'm still using the normal probes. But I don't think it's wrong to use cooled RF. I just can't make it work financially at my hospital.
Thank you so much.
All
Thanks
right.
a lot. Dr. Hassan,
Uh,
final words on
I
you.
don't have any other question. I want to thank Dr. Schneider one more time. It was a great pleasure for us. And I want to thank everyone who joined us this evening. Thank you.
Yeah, thanks for listening. Y'all enjoy your
Thank
evening.
you. And
Thank
you can
you.
run now.
Okay,
Bye-bye.
bye.